So welcome back to the channel, everyone. As you can see, I'm joined by the lovely Kat again. So if you haven't watched our first video where we talked about GLP-1s and digestion and all things diet related, then please do go and do that. So Kat is a nutritional therapist who specialises in weight loss and works with a GP clinic to support patients through their weight loss journey with and without GLP-1 medications. And what we wanted to talk about in this video is something really important, which is the impact of GLP-1 medication and your weight loss journey on bone health. One of Kat's areas of interest is around maintaining bone health in older life as we get to that menopausal period when everything starts to go wrong. So it thought it'd be quite useful to have a conversation around bone health and what people can do to support their bones. So Kat, over to you.
Thank you, Debbie. Lovely to be here again. Yes, it's interesting. I think that the bone health conversation is actually not talked about enough with those that are on GLP-1. I hear a lot about, the muscle mass loss, but there's not enough people also talking about, well, what's the potential for your bone? And I especially worry about those that are experiencing side effects such as hair loss or nails, because if they're also that's going, what's happening to their bones? But I think the main thing that most people don't understand is, along with any weight loss, you also lose muscle mass. And that's whether you're on the GLP-1 medications or you're doing weight loss naturally. There will be some muscle mass loss. Now, the greater the weight loss, so obviously that's more likely on the GLP-1 medications, then the higher the muscle mass loss. So actually, in some people, this can be 30-40% of that weight loss can potentially be that muscle loss. Now, from a bone point of view, that's really important because we want that muscle stimulus to help with our bones. So bone is why muscle mass is so important when you come to bone health, is actually that muscle stimulus creates our bones to recreate. So bone is a living tissue, so it's constantly breaking down and rebuilding. So in order to rebuild, we need to send it signals to rebuild. One of those signals is muscle to rebuild it. So that's where that it's, if we're losing muscle mass, we are also potentially going to be losing bone as well, which is a worry when we get older, because we need our bone.
We do. And I think that's the thing, isn't it, is you can see your nails going brittle and going weak. You can see your hair falling out. You can see your muscles becoming smaller and that definition going. But you only see your bones when you have a fracture or when you have a DEXA scan, don't you? And it's if all of this is happening that you can see, then that does raise alarm bells about what's happening to your bones. And as somebody that's had 14 broken bones, I'm a bit of a veteran to the old Broken Bones Society. And mine isn't from an osteoporotic perspective. I am just clumsy on 2 feet, and that is me. But of course, when you get older and you start to get that osteoporotic fracture, then that's when you start to get quite significant fractures from very little mechanistic accidents. And of course, if your bones are compromised, healing is compromised. And if we can do something to prevent that happening earlier on in our sort of journey through adulthood, then that's important, isn't it? And I think that's one of the reasons why weight-bearing exercise is purported as such an important part of osteoporosis support, isn't it? And it's that signalling that's doing that, isn't it?
And people really don't understand. I mean, I see a lot of clients that have got bone issues, whether it's because genetically, maybe they're not absorbing the vitamin D or the calcium or magnesium correctly, or maybe they've gone through things something like chemotherapy, or they've been on omeprazole for a long time, which can stop the absorption of some of your minerals. There are so many reasons, but I always remember one client, she'd gone through breast cancer in her late 30s, early 40s, and obviously was on a lot of chemotherapy, and that had followed by being on omeprazole for quite a while, in fact, too long. And she came to me with significant osteoporosis. She was only in her 50s. And it always struck me because it was so bad that walking through a door for her, knocking her hand, fractured her fingers. You're like, wow, how many times do we all knock ourselves? And we've had, she's had to, go on a real journey. So just thinking from a point of view is obviously for her, the mechanism for that was unable to eat so well when you're on the chemotherapy drugs, but also when she's on the omeprazole, the absorption of minerals. So you kind of got to play that into that GLP-1 picture with that loss of appetite. Does that mean the loss of the micronutrients and the macronutrients that are so important for bone? Everyone thinks that bone always just take calcium and vitamin D and you'll be all right. Actually, there was a study just recently in the British Medical Journal. It was a medical journal. It was an editorial on calcium and vitamin D, how ineffective that was for bone health. And I think the reason it is ineffective is a couple of reasons. One, maybe it was the type of calcium and vitamin D that is given perhaps by the NHS not being that well absorbed, but also bone health is not a calcium deficiency disease. And that's what I say to all my clients is it's not, you haven't got osteoporosis from a calcium deficiency or a vitamin D deficiency. It's an inflammatory disease. So you can pour all the calcium and vitamin D you want on those flames. But if that fire of inflammation is still going, it's going to have little effect. We need to work out what is causing that fire in the first place. It's an inflammatory. So what else can we do? Yes, calcium's important. Yes, vitamin D is important. But if you've got that inflammation going. So I think there's two things to think about with the GLP-1s. Do they actually help with osteoporosis because they lower inflammation?
There is some research to suggest that they do.
Yeah, absolutely. So there is a little bit of mechanism, but then also the other picture is if your appetite is so suppressed that you're not eating enough protein, which is really important for bone health, if you're not eating enough calcium, if you're not eating enough zinc, magnesium, boron, loads of, vitamin K rich foods, then you're compromising that bone health as well as not doing perhaps that weight bearing. So I think the evidence is still out. Does the GLP-1s cause osteoporosis? I don't think we're there yet. Haven't got the research and we don't know for sure. But if you're not doing the right things, then you're definitely got to be also worried about your bones, I think.
Absolutely. And I think to follow on from that, we know that obviously a lot of GLP-1 users end up with heartburn and reflux. And obviously the natural support for heartburn and reflux from a very simplistic view is to take a PPI. So if you're on a GLP-1 and you're on a PPI and you're not eating and you're not exercising, then you're literally, you're pouring straws on the camel's back, aren't you? And at one point that's going to stop because, bones originally, obviously, they are minerals, but they're also collagen. And that doesn't mean taking a collagen supplement is going to solve that issue for you. But if you're protein deficient, then where is that protein coming from? And you're right, the body manages calcium so that you don't die. So it's not just about having calcium in the system. It's what else is going on in the background.
What else is going in, but also directing that calcium to the right place, to the bones. But again, without collagen for your bones, your collagen is made up, your bone is made up of collagen. Without enough collagen, there's nothing for the minerals that you're consuming to adhere to. So again, so that comes down to collagen, so that comes down to protein. I do usually with my osteoporosis clients put in a collagen, particularly for the bones. So again, not all collagens have got the right molecular density to reach your bones, and not all collagens will hit the bones. So a marine collagen, for instance, is not necessarily targeted to the bones. It does need to be a bovine collagen, and it does need to be a collagen that is specially got the right molecular strength to get into the bone.
Yeah, and that's important, isn't it? I know there's a lot of noise around collagen and there's a lot of medical claims, But there is a particular collagen that is marketed for bone health, and there is quite a lot of robust evidence to suggest that that's helpful. And I know that that's something that you use quite frequently with your osteoporosis patients. And of course, because collagen is a food, I will sort of mention the brand. It's called Bone Balance, but I would always encourage people to look at whether that's appropriate for them with whatever else they've got going on medically. But it is something that if you have got osteoporosis can be useful. But I'd always encourage people to work with somebody qualified to help support that process, because like you say, it's multifaceted, isn't it?
Yeah. It really isn't a case of just making sure you're hitting your calcium. It is so much more. That's a conversation I have with my clients. Are they actually eating enough calcium? And sometimes actually hitting that 1,200 milligrams, which is the usual. If you've got issues with your bone, that's the usual kind of dose you want to be on. And I say dose as in food first. That is still a dose, not just if someone was coming to me with 1,200 milligrams of a calcium supplement, I would immediately get them to stop that, because that's way too high. Ideally, we want mainly food, and we work out what their calcium is with food, and then I might need to top up slightly with a calcium supplement, but it's got to be a calcium supplement that's also got all those cofactors, so that calcium is directed to the bone and not hanging around in your arteries, because calcium shouldn't be in your arteries.
Absolutely. And I think anybody watching this, if they're thinking, well, how do I know how much calcium is in my food? There's a really good calculator on the National Osteoporosis Foundation website where you can put in your daily food and it will tell you whether you've hit your calcium targets, assuming that your digestive system is working to its optimal. So, of course, if you are taking a PPI, then that is going to impact the extraction of your calcium. And obviously, how would a patient go around finding out what their bones are like? I know there's a number of different tests that people can do.
There are a number. I think the gold standard still is a DEXA. I do think that's recognised by your GP and it's recognised by the NHS. You will only be eligible for a DEXA on the NHS if you have a family history of osteoporosis or you've broken, I think it's 2 bones in an unusual kind of format. You would probably be sent off, Debbie, all the time.
I've had a couple. I have had a couple.
They're going to be checking. So again, they don't necessarily do it. What's interesting is actually if you're over 80 and you've had a fall, they automatically assume you've got osteoporosis, and they actually give you the osteoporotic drugs without doing a DEXA first. So I found out from my father-in-law. He fell onto a concrete floor last Christmas in his garage. He was up a ladder, over 80 anyway, 83. Shouldn't really have been up this ladder. No. He's been banned from ladder use.
My father-in-law same age and been banned for similar reasons.
So he fell onto a concrete, garage floor, and he shattered his hip. They put him on the bisphosphonates. He didn't realize what he was what he was being given. They didn't give a DEXA. And I said to them, when I was kind of going through it, because he had really horrific side effects actually to the bisphosphonates. And so I was like, well, did they do a DEXA to actually see whether you had osteoporosis first? And they didn't. So I then said, because he had such horrific side effects and they were offering him his second one, I said, you're going for a DEXA. Let's actually see where your bones are so we can make a judgment call first to see whether it's the right thing. So the DEXA is the NHS thing. You can get a DEXA scan privately. I use a clinic in London that I refer clients to because I want to get a baseline. What is your DEXA? But you wouldn't have, because a DEXA is an X-ray, so you don't have it more than, you don't have it every 6 months. You'd only have that every 2 to 3 years. So that's your baseline. So what I use for monitoring in between is a REMS scan. So that's REMS. Don't even ask me to. It's a very long word of what it actually stands for. But so a REMS is different. So that's more like an ultra scan. So it's got no radiation, so that you can have that regularly. And it gives you a T-score as a DEXA scan does, but it also looks at the strength of your bone. So it gives you a fragility score as well. So it's looking at bone, not just from a bone mineral density point of view, but also a strength of your bone. And I find this really useful, especially for clients in their 50s that might have been told they've got osteoporosis or osteopenia and they need to take the bisphosphonates. I'm like, right, well, quite often clients will come to me before they've gone on the bisphosphonates to have that conversation. I'm like, look, I'm not saying anything about whether you should take the medication, but let's have the REMS scan first so you can see what the strength of your bone is like, because then that will help guide you on that decision whether to take the bisphosphonates or whatever medication the NHS might deem more appropriate for you. And I find the REMS really useful because, again, you can have it regularly. So if someone's got poor bone mineral density, actually they're recommended to have it every 6 months. Are the changes they're making really impacting? Unlike a DEXA, where you've got to wait 2 to 3 years to see that change. And I think even on the NHS, some of my clients, it's 5 years. So again, we quite often squeeze a private DEXA in or do the REMS much more regularly so they can see, are the changes I'm making actually having an impact on your bones, especially when we know the importance of lifting weights and weight training. And if there's a fear around bones, actually, am I doing damage maybe by doing the weight training to my bones? So having that REMS shows actually what you're doing is, look, it's making a difference, it's actually improving. And that then gives them the reassurance, actually, my bones are strong, so maybe I can introduce some impact training as well. Because otherwise they're scared of doing any impact training. They're scared of picking up weights because they are scared of breaking that bone. Now, of course, that there is that fear element, but we need to give them I think the REMS gives you the confidence actually to push your bones a little bit. Yes, you've got a poor mineral density, but look how strong they are. And that means that actually they can take a little bit more strain than perhaps you've been giving them up till now.
Yeah, and I think that's the important thing as well, isn't it? Because if you are taking bisphosphonates, then for some people that absolutely is the right thing for them to do. But there is a point at which the bone starts to become too hard, and there's a secondary risk that you'll have fractures, because it's almost like when plastic gets sort of left out in the sun and it becomes brittle and then it breaks for a different reason. So actually making sure that you do have that DEXA scan at 5 years to see, because somewhere between 5 and 10 years is usually the optimal window for a bisphosphonate. And a REM scan is quite a good interim measure, isn't it, to see where you are from that.
Exactly. So and again, I think some of the the bone consultants now and the orthopedic surgeons are some of them are open to the REMS as well. Beforehand, it was like, oh, it's a bit new, I don't quite know what it is. But actually, I've had clients that come to me that we already had a REMS from, like, their orthopedic surgeon has advised them to go down that route. And it's been like, oh, you know about REMS. Wow. Because most people haven't heard of REMS. So that, they've already given me the results. And then that's really nice, tying that up. And then I had one client recently, and she had a REMS almost just before our consultation. And then our first consultation, we worked together for about 6 months, and she had another REMS after, and she's like, wow, I can really see the improvements in just me pushing her a little bit with her protein and her nutrients and her weight training. And you could see that the difference had definitely strengthened. So it's a useful and really interesting thing to do, that REMS.
It is. And I think if anybody's in that osteoporosis sort of window, one thing that I always advise people to do is to make sure that you've had a dental checkup before starting on a bone density medication, because certain dental issues, which your dentist will be aware of, can increase your risk of the jawbone actually starting to crumble. So if you are looking at starting on some osteoporosis medication, do always chat to your dentist before. But Kat, before we finish, what would you put as your sort of top 3 things to do to support your bones sort of going forwards?
Again, it depends on if someone's got osteoporosis or not, to what they can do. But, say I've got someone that, sitting in front of me and we've got osteopenia, you've got to do weight training. Absolutely. Without a doubt, you've got to do some weight training, and you've got to do some kind of impact if you've got osteopenia, and you need to make sure you're eating enough protein. So those are the three things if someone's got osteopenia. If someone's actually got more advanced bone health, so obviously what you have normal bone density, then you've got osteopenia, which means that they have started to reduce in density, but we're not looking at, kind of serious case. And then you've got osteoporosis, and it just depends on how bad that osteoporosis is to what potentially they can do. They still need to be eating enough protein. They need to be lifting some weights, but that need to be guided with a physiotherapist or a personal trainer that has experience of working with clients with osteoporosis. Absolutely essential. Not all personal trainers and not all physiotherapists will be understanding of what the exercises are right or wrong to do. You can do an awful lot of damage with weights if you are not looking, not trained. And then actually with someone with some of the impact, I'm also really cautious of people who've got osteoporosis that's bad, some of the impact training. But things like standing up and just doing heel drops, so your weight on your heels, which is usually the strongest bone, actually you're still getting some kind of impact, but it's not whole body impact like skipping might be. And you don't need to do skipping with a skipping rope. You can pretend and do that kind of thing. Even like jumping off the stairs. So when I go upstairs, I walk up my stairs very quickly, and I jump off the bottom stair. I don't advise you, Debbie, with your accident prone to do this. But if someone is jumping, I've got several steps in my house, and I quite often jump in them. You don't want to be jumping around in trainers either, because that will absorb a lot of the impact. It's meant to be 3 times the impact. So actually just sort of 7-8 inches is enough of an impact to get that 3 times your body weight. So barefoot trainers, but I tend to walk around barefoot in my house, and jumping off those steps is really useful. But if you have osteoporosis, you have to be super, super careful with that impact training. I also do Nordic walking myself as well, and that's got some evidence that you're walking itself actually is not enough to stimulate your bones, but walking up a hill with Nordic poles, actually you're striking the ground, especially if you're on a road. We're quite noisy as we go around around the villages around me, but you're striking down, and that actually is meant to be quite good for stimulating that bone.
That brings back memories of, I've got some Nordic walking poles, and I used to take them to work with me, and the village where I used to work is a village called Parbold, and it has like a bit of a hill, and it's got quite a nice circular loop. And in my lunch break, I would sometimes go out with my Nordic walking poles and Nordic walk poles around the village. All the villagers knew who I was. I didn't have any problem. And I remember I was doing it this one day, and there were some workmen, and I was like, oh. So I was like trundled past them quite happily, and I'd gone past, and one of them suddenly shouted, "You forgot your skis!"
Yes, we do get comments like that. But the villages around us, I think, quite know that we are the Nordic walking crew, and we will be quite noisy. You can definitely hear us coming. We're very good. If there's horses or dogs, we will lift our poles so we don't frighten them. But another useful exercise actually is a plank actually on your hands, because actually the most common place, apart from kind of falling and breaking a hip when you're older, is wrist fractures. So actually going into plank with your hands actually strengthens your wrist. So that's quite a useful little exercise. And most people can do that, holding it. So again, trying to increase.
7 of my fractures have been wrists.
So there you are, Debbie. I'd like to see more planks from you, please.
That's noted. You will not be seeing it on a YouTube video anytime soon. That is not a vision anybody needs. But I will promise that I will do some planks just for you, Kat.
Yeah. And then also making sure people have got good balance as well to avoid the fall in the first place. So actually things like practicing standing on one leg, actually if you can stand on one leg, can you do it with your eyes closed, for X amount of time. So I quite often check, and I will do balance kind of training. I will quite often stand on one leg in various different forms.
Yeah, I've done that. I used to have, is it the Bosu, the half ball?
Oh yeah.
And I used to go and work with a PT, and sometimes it would be flat on the floor and I'd have to stand on it. And then sometimes they'd turn it upside down and I'd have to stand on the base bit. And my PT would be like that, waiting for me to fall over. So yeah, proprioception is definitely one of my downfalls.
So that again, it's looking at why someone might fall in the first place, but also doing blood tests. What's your vitamin D status? Most people, I have had so many people. I think it's timing of year, come off for a long winter, maybe they haven't been away and just not getting any vitamins, because obviously vitamin D is through your skin, so it kind of acts like a hormone. So if you haven't got the sun hitting your skin, you're not going to get any vitamin D. And I've had most of my clients, if they've done blood tests, have been not just low, they've actually been insufficient, like really, really low. And that's really important, because without that vitamin D, you don't absorb calcium as well from your food.
Yeah, absolutely. And I think to follow on from that, obviously, once you're in menopause, especially if it's been a sudden early menopause, that can obviously increase the risk, because estrogen does play quite a role in bone turnover. And if you're a thyroid patient, is actually making sure that you're not overtreated. As we get older, there's often a need for thyroid medication levels to be lowered. And of course, if you're being overtreated, that can cause you to burn through more calcium than you should do. So, if you are worried, it's always good to have these conversations with your GP and get tested and make sure that you're proactive before you do have that accident and then you've broken a hip or worse.
Yeah, I did see some research that those that are on levothyroxine are more likely to have poor bone mineral density as well. So I don't know. Is that link, or there's another link?
It's probably a combination of things. I know certainly because thyroid function fluctuates quite dramatically throughout the year, and patients are normally only tested once a year, there will be phases through the time where they are probably a little bit more overtreated than others. So whether there's a degree of that, knowing that something is a factor doesn't always help us to understand why, but I do know that there is some quite rapid variation throughout the year, which undoubtedly plays.
Yeah, and of course, levothyroxine is only medicated on using just one marker, the thyroid stimulating hormone, which is not the whole thyroid picture as well. So
so you could have more T4, and it's even if you're not being converted into the active hormone, the inactive hormone still impacts your bones. So if you are watching this and you're somebody that's self-medicating with your thyroid medication, which I know a lot of thyroid patients do, especially if you're taking T3, which doesn't have that gatekeeper on it, you do have to be really careful about your bone health. And I think being proactive is always much better than reacting after.
Yeah, I wish that, on the NHS, like we have our mammograms, it would be lovely that every 50-year-old woman actually had a DEXA scan. What's their bone? Because wouldn't it be lovely if we found out what their bone health was at 50? And then where you haven't got such an inflammatory picture, then at 75 when you've had your first fall, and then you find out you've actually got osteoporosis, where if you tested you at 50, it might have been, you know what, your bones aren't looking brilliant. Maybe you need to do a little bit of weight training or impact training, and when you can do it, rather than at 75 and actually you can't do anything, they're really bad,
Yeah, it's definitely a prevention is better than cure situation, isn't it?
Definitely. So it would be lovely. I was doing a talk once, it was a menopause talk, and there was a lady from Switzerland there, and she said it was something that was part of their a healthcare, everyone. I think they pay for it in Switzerland, but they did get their DEXA as part of their tick list MOT at 50 kind of thing.
Yeah, but it is certainly something, if you can afford to pay for a DEXA scan at 50, it is certainly something that's worth considering.
Depending on your area, it's about 120 to 150 pounds. So it's, it's not, break the bank. And then, of course, hopefully you only need one, i.e. my bones are good, or I need to do a little bit. And then, of course, if you have got, poor bones, you can then get more on the NHS then, because you've got that evidence to take to your GP.
Absolutely. And I know certainly here, one of the local hospitals does private DEXA scans on the weekend to help to raise money towards other services. So it's always worth speaking to your local NHS hospital to see if they do offer the option for you to pay, because they generally charge a reasonable amount of money compared to a private provider. So it is worth asking that question. I know certainly when I was having my DEXA scan done at Warrington Hospital, there were people there that were paying for a private one. So it's, it is possible to have that.
Yeah.
Well, thanks again, Kat, for joining me for another interesting conversation. And I think even if people aren't on a GLP-1, the whole osteoporosis conversation fits with so many people. So if you have watched this video and you want further support, Kat's details will be in the comment section. There's a raft of qualified nutritional therapists out there that could equally help you to navigate that journey. If you haven't subscribed, please do consider subscribing so that you find out more videos as and when they pop up. And feel free to drop a like and a comment on this video to help other people see it, because the whole purpose of this channel is to raise more awareness amongst practitioners and patients around some of these things that we can be more proactive with rather than waiting until the damage is done. But until next time, I hope you've enjoyed that, and I will see you soon. Thank you, Kat.
Thank you. Bye.